And Assalamu alaikum. I'm Dr. Kamran and I'm a consultant thoracic surgeon working at CMH Rawalpindi. I'll be pneumothorax for our high risk population of patients, that is the armed forces personnel who are working in the length and breadth of the country. I am here to share with you our center's experience. As you all know, pneumothorax is presence of air in the pleural cavity described as early as the 18th century, and there are two peaks of incidence. The earlier peak is predominated by the primary spontaneous variety, and the second peak, which is later on 50 to 70 years, it is mostly by secondary spontaneous pneumothorax. And the classification, the etiological classification, here you find spontaneous and traumatic pneumothoraces, and primary is the one where you don't find a cause, where you don't find an underlying lung disease. Then the closed, tension and open pneumothorax, and then the radiological classifications. So primary spontaneous pneumothorax is pneumothorax without any known previous lung disease. There are two theories that are postulated: the formation of blebs and their rupture at the apical segment, most commonly of the upper lobes and then of the lower lobes. Then the pleural porosity theory, in which the surface of the lung, these cells become inflamed and they leak, and it is more common, primary variety, it is more common in tall and lean control patients, the so-called Marfanoid patients, in which there is increased gradient of negative pleural pressure compared to the base till the apex of the lung, which forms the bullae or the smaller plebs, and they rupture and pneumothorax happens. On the contrary, secondary spontaneous pneumothorax occurs most frequently in COPD and bullous lung diseases and a variety of other diseases, lung diseases. So we can manage primary spontaneous pneumothorax by non-surgical means, from observation to oxygen therapy to simple aspiration, needle aspiration, placing pigtail catheters, even chest intubation in few cases. None of these are reserved for the first episode of pneumothorax, primary spontaneous pneumothorax, that is uncomplicated first episode. Surgery is reserved for some conditions, both VADS and open. I will be talking mostly about VADS today. So here you can see there is no mention of surgery in uncomplicated first episode of primary spontaneous pneumothorax. Complicated is where there is non-expansion of lung on chest intubation, there is prolonged air leak after chest intubation, or when there is tension pneumothorax or hemopneumothorax. The problem with PSP is very high rate of recurrence. This is the Achilles heel of this condition. According to a meta-analysis, the 1 year recurrence rate is as high as around 30%, and overall recurrence rate goes up to this is 37% average, but some studies state that it can be as high as 60%. So the indications of surgery in the first episode are only prolonged air leak, non-expansion of lung. This is occupational hazard, and I've highlighted it because our group of patients, they are high risk groups. You see, we recommended in the first episode in pilots where there are a lot of other lives depending on them. The people who live at longer distances from hospitals, in the mountains, parachutists, and we at Combined Military Hospital are dealing with patients who are soldiers, who are sailors, who are airmen from Air Force, Army and Navy, and so we are doing them, operating upon them after even the first episode. After second episode, be it ipsilateral recurrence or a contralateral recurrence, there is indication for surgery. The surgery can be open or it can be by VADS. And what you do is you do the apisectomy, which we call also apical stapling. Then the apical part of the hemithorax, where the fluorectomy is done in order to make adhesions between the lung and the chest wall or abrasion of the lower part of the lung. It is another debate whether to go for a BATS approach or an open approach. The recurrence is less in open, but the cost is more and other problems are there like post-op pain, longer hospital stay and all that. So as per BTS guidelines, British Thoracic Society, video-assisted thoracoscopic surgery with thorectomy and pleural abrasion is better tolerated. It does have a slightly higher recurrence rate, 1 to 4% compared to open, but it is very much better tolerated. So our experience starting from August 2010, this was from two centers, CMH Lahore and CMH Rawalpindi. And all the patients who came to us with primary spontaneous pneumothorax were included, where we were going to operate. The procedure was vasectomy and thorectomy and or abrasion. And all the patients with secondary spontaneous pneumothorax, they were excluded from the study. The total number was 163 patients. The predominant symptom is always chest pain in these patients. In primary spontaneous pneumothorax, the predominant symptom is pain compared to secondary spontaneous, where the breathlessness is more common and there is lesser pain. Fever was only there in chronic cases, old cases where they had development of emphysema. Chest X-ray, plain chest X-ray PA view was done in all the patients as a diagnostic tool, and where we wanted to go for surgery, we carried out an HRCT in those patients to rule out secondary spontaneous pneumothorax. Here you can see X-ray of a patient where a chest tube has been placed. In this X-ray you can see it here, in this CT scan it is there, and despite intubation the lung has failed to expand. The year-wise cases, it was almost a steady number, apart from a slight decrease in the days of COVID pneumonia when the number was a little less. The male to female ratio, since we have a majority of male clientele are soldiers, so 142 patients were male and only 21 patients were female. The age range, as you can see, majority of these patients, they were 20 to 30 and then 30 to 40, so it was more common in young age as described in the literature. The indications, 36 patients where it was a recurrent attack, be it the second attack or a third attack, and in the first attack in 104 patients, all done in soldiers, sailors and airmen. We think that they serve in Himalayas, in Siachen, in Kashmir and far off places on the ships. So in case of recurrence, there can be problems, there can be danger to their life, so we operate in the first attack. And then persistent air leak in 19 and contralateral recurrence in 4 patients. The operation under general anesthesia, the patient with double lumen endotracheal tube in one lung is collapsed and 3-port technique is used. The anterior port is the working port. This is the camera port in the 5th intercostal space in the mid-exervay line. Episectomy of upper lobe was done in 151 patients, lower lobe and both in 4 patients. This is the Vanderschouren staging, no endoscopic evidence in 9 patients, some adhesions after ruptured bulla in 16 patients, and then blebs were visible in 120 patients. The procedure itself, I'll show you a brief video just to demonstrate the picture. Here you can see, this is the apex of the lung, this is the right lung, right apex. And you can see a few small blebs which are here. And this is a linear endocutter, a stapling device by which this would be divided and stapled off. Since I am getting short of time, so forward. Next, I will show you pleurectomy being done. This is how you peel off the pleura from the chest wall, and once it is peeled off, there is a raw surface which would promote formation of adhesions of the lung with the chest wall. So you obliterate this space where air leakage can occur and air would collect. This is how a bleb would look like endoscopically, thoracoscopically, and this is the part of lung being resected. This is a stage 3 bulla, that the one which is less than 2 centimeters in size, and this is the staple line after this has been stapled off. Pleurectomy carried out, and this is after pleurectomy. It looks like this. Pleural abrasion of the lower part of the hemithorax, punctate bleeding is seen on the diaphragm and the inner part of chest wall, and this is a resected bulla, and this is resected pleura. This is just 3 ports post-operatively. You can see the patients. This was the port which was used for chest tube after the surgery. You can see the staple line here in a post-operative chest X-ray. We followed up all of these patients at 3 months, 6 months and 9 months. And this is the profile of our complications, conversion into to open surgery. We had to go for axillary thoracotomy in 2 patients only, and fortunately there was no mortality. I'll just skip a few slides due to shortage of time. We published our data, a study in 2011 in 30 patients, and then in the Journal of Pakistan Medical Association in 2021 in more than 100 patients, and this study which I presented today is just a continuation of the previous one. So I conclude by saying that it is an effective management. VATS is an effective management and should be considered even after first episode in high risk groups, in complicated first episode, and those who vouched for a definitive treatment. Thank you very much.
तो प्लीज़ अटेंडेंस लगा लें, CME आवर्स के लिए आपके पास आ रही होगी, ठीक है? थैंक यू. और अगेन रिमाइंडर, टाइम इज 10 minutes. There will be 2 bells and you have to stop after second.